Good afternoon, everyone. We'll just wait a couple of minutes to let participants come into the webinar. I see some of you are joining us, and we'll just wait a couple of minutes and we'll get started around noon. Thank you so much for joining us. Okay, welcome everyone. Good afternoon. I just wanted to introduce this webinar that Prenatal Screening Ontario is doing in collaboration with CMNRP. So today's webinar will be navigating the prenatal genetic screening landscape in Ontario. I'm just going to start sharing my screen so you guys can let me know if there's any technical issues. We have some of our teams here in the panelists that will be able to help you with any tech issues if you're having them. So the first thing I wanted to do is in land acknowledgement. I would like to begin by acknowledging the land on which I stand today. So I'm in Ottawa, which is the traditional territory of the Anishinaabe people. These people have lived on this territory for millennia, and we honor them in their land. Their culture and presence have nurtured and continue to nurture this land. We honor all First Nations, Inuit, and Métis people in their valuable past and present contribution to this land. I encourage you and invite you today to reflect on your own land acknowledgement wherever you're joining us today from. A couple of things we just wanted to share with you before we get started as well. So we wanted to introduce a language statement about gender inclusivity. So during this webinar, we may use gender language, for examples, mother or maternal serum, or anything related to prenatal genetic screening, which Joanna will let you know. But this is really meant to be inclusive of all individuals, including those who do not identify as a woman or a female. Most importantly, we recognize and respect the rights of all people for whom this information contained in this presentation may apply, including but is not limited to transgender, non-binary, and intersex people. We also encourage all healthcare providers to engage in a respectful conversation with patients and colleagues about their gender identity and preferred pronouns, to apply knowledge in a way that is sensitive to each person's needs. Before we get started, we just wanted to review some housekeeping tips with you. So here you see the Q&A box. So we invite you to use the Q&A box to put in any questions that you have. The presentation will take about 40 to 50 minutes, and then at the end we'll have a period of questions where we can get to your questions. At that time, you will be able to raise your hand. So during the presentation, all attendees have their microphone muted. This is to ensure clear sound for the speaker, but at the end you will be able to raise your hand and speak to a question you may have if you choose not to put it into the chat box. Into the question and answer box, sorry. The chat box has been disabled because we really encourage you to put all of your questions in the Q&A box. On the right top screen here, you see the social media as well. So if you want to follow Ontario PSO or Prenatal Screening Ontario, you also have the CMNRP lens as well. Excellent. So again, just before we get started, if you're not too familiar with the Champlain Maternal Newborn Regional Program, or what we call CMNRP, for those who don't know, we support the coordination of perinatal health services in the Champlain and Southeast region. So our program has partners which include hospitals that provide obstetrical and newborn care. We have public health units, community health centers, midwifery, and family practice groups as well. And really, we work together on key initiatives to ensure standardized, data-driven, and evidence-informed and family-centered care across the region. We also have great networking with some of the provincial and regional networks as well. So within my role as CMNRP, I am privileged to be a member of the Born Education Working Group, where I got to meet Joanna and where we started working together. So before we get started, I wanted to introduce our guest speaker today. So Joanna Miron is a certified genetic counselor, and her main role at Prenatal Screening Ontario is to develop and implement education initiatives related to prenatal genetic screening. Before joining the Prenatal Screening Ontario last year, she had practiced as a clinical genetic counselor for almost 10 years in the prenatal diagnosis and medical genetic programs at Mount Sinai Hospital in Toronto, sorry. In addition to her Master of Science in Genetic Counseling, Joanna holds a Master of Science in the area of cellular signaling research, both from the University of Toronto. So without further ado, I would like to take the opportunity to welcome Joanna, and please go ahead and start. We'll just give us a couple of seconds in transitioning to make sure that Joanna can share her own screen as well.
Hi, everyone, and thank you, Catherine, for the introduction and the opportunity to provide this webinar today. So yeah, just give me 2 seconds to just get set up here.
This looks great, Joanna.
Okay, perfect. Yeah. All right, so I guess you've seen the title of my talk. It's Navigating the Prenatal Genetic Screening Landscape in Ontario, which seems to be getting increasingly more complex. Hence the purpose of the webinar today. So I have 3 main objectives. Let me see if I can move this along. Okay, so one is to compare the timing, components, and performance of the different prenatal genetic screening modalities in Ontario, identify which prenatal genetic screening test to offer depending on clinical circumstances, and also touch upon the differences between prenatal genetic screening and diagnostic testing. So these are all 3 hefty goals. I won't be able to cover everything in detail, so feel free to ask your questions at the end or reach out to me after the webinar. So I'm going to use an interactive tool called Mentometer. It is up to you whether you wish to participate. I think it makes it a little bit more fun and interesting to see everybody's answers, and it's also better than just talking to myself. You can scan the QR code with your camera phone, or you can go to menti.com and use the code that you see on the screen. You can also add reactions and temporary comments as you go along as well. So as you're getting set up, I guess we can just start out by testing out the tool. Okay, some of you already logged in, that's great. And I'd like to begin by acknowledging the land on which I am privileged to live and work, and which region of Peel operates as part of the treaty lands and territory of the Mississaugas of the Credit. In particular, I acknowledge the territory of the Anishinaabe, Huron-Wendat, Haudenosaunee, and Ojibwe Chippewa peoples, the land that is home to the Métis, and most recently the territory of the Mississaugas of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. I would like to offer my gratitude to Indigenous people for their careful stewardship of these lands in the past and acknowledge their present contributions. And in terms of, I guess, in terms of this land acknowledgement, of course, this is only the first step, and at Born, we are committed to continuing the work towards reconciliation. I would encourage you to visit the Born website, and it's the Indigenous Wellness section of the Born website if you wish to learn more. And this is a picture of my little boy and on a beautiful August morning on a sunflower field that's within walking distance from my home. So just a couple of slides about Born. So you may have heard of Born already. Born is Ontario's maternal, newborn, and child registry. Registry status basically means that it allows Born to collect, use, and disclose personal health information without consent, as long as the purpose is to facilitate or improve the provision of healthcare. So the registry actually currently holds the data for more than 1.4 million children, including data on all prenatal screening modalities, pre and postnatal cytogenetic results, and birth outcomes. And Prenatal Screening Ontario was born out of Born, so to speak, in 2018 to coordinate prenatal screening services in the province. Born and therefore PSO, we are funded by the Ministry of Health and administered by CHEO, Children's Hospital of Eastern Ontario. Okay, so you're here to learn about prenatal screening, so we'll get started. So to begin with, there are really 2 main branches or 2 main types of prenatal screening. One is multiple marker screening. You might not be as aware of that term, but basically within that, there's enhanced first trimester screening, or EFTS, and maternal serum screening, or MSS. Both of these are Ohip funded. And then in the other category, we have non-invasive prenatal testing. It's also known as cell-free DNA. You might have heard about it. I still hear it being referred to as the Harmony test or the Panorama test, although these are, brand names. And I'll refer to it as NIPT for most of this talk. So I'll start with EFTS because that is the most common prenatal screening modality in the province. And then I'll talk about NIPT and how everything fits in together. So EFTS always will screen for two different chromosome differences. One is trisomy 21 or Down syndrome. That's when there's an extra chromosome 21. It would also screen for trisomy 18, which is a much more severe condition. It's a life-limiting condition. That's when there's an extra chromosome 18. In both circumstances, these babies will have 47 chromosomes instead of the typical 46. The chance for these chromosome differences can occur at any age, but it increases with maternal age. I have linked to a chart here that you can see at the bottom, which shows you the chance of chromosome differences based on maternal age. So you will have access to the PDF after the webinar, and you can just click on it and it will take you to that chart. And I've scattered resources all throughout the talk. What I'll mention is that if trisomy 18 is not on the final report, it means that the patient is screen negative or low risk for that condition. So you won't see it actually on most reports, but rest assured it was screened for it. So just some basic information about EFTS. It has to be done within a certain time window. And the cutoffs have recently been standardized across the 3 serum screening labs in the province. So North York, Trillium, and Mount Sinai. So the time windows, it corresponds to 11 weeks, 2 days, to 13 weeks and 3 days gestation. There are 3 main components to the screen. The first 2 are the most important in the algorithm. So the maternal age, or the age of the oocyte provider, and the nuchal translucency measurement. The third component is the blood work, and that is also important. And depending on which serum screening lab you send the blood to, it will either look at 3 or 4 hormones that are released by the placenta or the fetus. I don't have it on here, but the clinical information is also important, so please fill out the form appropriately. So the weight, smoking status, that I've seen it make a difference between a screen positive and a screen negative result. So those also play a role in the algorithm. So at the end, the computer comes up with a risk estimate for Down syndrome. And so if that risk figure is higher than 1 in 350, then the patient gets a screen positive result or higher risk. If it's lower than 1 in 350, then it's screen negative or low risk. So it's just a way of placing people in one of 2 categories. The median turnaround time based on the born data that's recently been released is 4 business days. So that's from the date of sample collection to the date the test report is issued. And it can be done for both singletons and twins. So in terms of how to order EFTS, there's really 2 main requisitions that are needed. One is the Anti-Ultrasound Requisition, and the other one is the blood work requisition, which is the multiple marker screening requisition or the prenatal screening requisition. It has different names, but it refers to the same thing. So you may have your favorite ultrasound facility already that you like to send patients to. But if you are looking for another location that's closer to the patient's home, for example, you can use this map on our website. You can actually zoom in on your location of choice and contact the facility of interest to obtain that requisition. In terms of the blood work requisition or the multiple marker screening requisition, I would say make sure you have the most recent version, which is March 2020. So this is the requisition that is partially filled out by the sonographer at the time of ultrasound. and that's the requisition of the patient needs for blood work. Even though there are 3 labs that do this test, you really should be sending to just one of them. Which lab you use depends on your location, not the patient's location. So it should always be the same one. And you'll see a map on our website if you're unsure. So we do have a phone line, and we do get calls fairly frequently from patients that are unclear about how to get the enhanced first trimester screen. Of course, we only hear about it when the process is not going smoothly. It's probably going just fine most of the time. But we did create a leaflet to help with this process a little bit. There's basically confusion at every step of the process. Sometimes patients get the requisitions from the provider and they're just not clear about who they need to call to book these appointments, and if the ultrasound goes first or the blood work goes first. Sometimes they think they have to go to North York to get their blood work done because they see the North York logo up at the top. So hopefully this leaflet is of use to you, and you or your admin staff can hand it to the patients along with the requisition. So this is my first real question, since you all know how to use Mentometer now. What is the threshold for an increased nuchal translucency? 2.5, 3, 3.5, or 5? I'll give you a minute. See, a few of you have voted. So let's see. Okay. Okay, so I suppose most of you voted 3.5 millimeters, and that is the correct answer. So it is a hard cutoff, 3.5 millimeters. So I just wanted to remind you all of that. We would say if you see that measurement on the nuchal translucency ultrasound, you don't even need to wait for the enhanced first trimester screening results. You can go ahead and offer a referral to a genetic center to that patient. An increased nuchal translucency is associated with conditions beyond trisomy 21 and 18, and I could spend an hour talking just about that. Yeah, I think it's just a reminder for you to know that 3.5 millimeters, it was a bit of a magic number, not 3.4, it's 3.5. So this data has just come in. So this is based on born data. So these are Ontario pregnancies. Only Singleton pregnancies were included from September 2016 to June 2020. And it outlines the performance of the enhanced first trimester screen. So the detection rate for trisomy 21 or Down syndrome is just over 88%. So that means that 88% of pregnancies with Down syndrome will be flagged as screen positive with the screen. Okay, and the false positive rate is 6.3%. So 6.3% of pregnancies that do not have Down syndrome will incorrectly get a screen positive result. Trisomy 18 detection rate is just under 84%. False positive rate is quite low. These are the main points about EFDS. Now, if patients find themselves in the second trimester and have not had screening, so if they cannot get an anti-ultrasound or if they present late to care, for instance, they can have maternal serum screening. There's no anti-ultrasound as part of that screening, so it consists of maternal age and blood work. With that being said, a dating ultrasound is highly recommended. In terms of the threshold for the screen, it's traditionally 1 in 200 for Down syndrome. However, at the beginning of the pandemic, we were getting lots of calls on our phone line. There were concerns about people's ability to get the anti-ultrasound because some clinics were closed or they had reduced hours. So then the question became, okay, if people cannot get the enhanced first trimester screen because they can't get the anti-ultrasound, how can we make sure that they can still get a high quality screen? So the threshold got temporarily changed to 1 in 350, and it's still valid until at least March of next year. So what that did, it's basically casting a wider net. So it increased the detection rate using the maternal serum screen so that it's similar to the EFDS. But now the false positive rate is a little bit higher as well. So that's the trade-off. And MSS can only be done for singletons. Okay, so if you have a patient presenting late to care who's carrying a twin pregnancy, MSS is not an option for them. All right, so how does NIPT fit in with all of this? So I will just start with this section from the NSOGC guideline from 2017, which is entitled Update on Prenatal Screening for Fetal Aneuploidy, Fetal Anomalies, and Adverse Pregnancy Outcomes. So first off, discussion of risks, benefits, and alternatives of the various prenatal diagnosis and screening options, including option of no testing should be undertaken with all patients prior to prenatal screening. And essentially, these are the options that you should present to your patient in the Ontario context. One, they have the option to decline screening. They have the option for standard prenatal screening, which in the context of Ontario, it's EFDS and MSS, depending on how far along they are in the pregnancy. Invasive testing when appropriate indications are present. So it's not recommended yet for average risk individuals in Canada, but if there's an increased nuchal translucency or there's ultrasound abnormalities, it's a discussion to be had. Or a screen positive result. And then the fourth option is maternal plasma cell-free DNA screening. So that's NIPT, where available with the understanding that it may not be provincially funded. So what you can take away from the statement is that it is reasonable to offer NIPT to average risk individuals, not just to those who qualify for Ohip funded NIPT. And that's in line with many other guidelines, international guidelines. Okay, so briefly about NIPT. NIPT analyzes cell-free DNA originating from the placenta that circulates in the bloodstream of the pregnant individual. So you see here in the picture, it refers to it as fetal DNA. It's a bit of a misnomer. It's really the placental DNA. And that's an important distinction. Placental DNA and fetal DNA usually are the same, but that's not always the case, which is part of the reason why NIPT is still a screen. It's not a diagnostic test, so it can still be wrong. It's definitely a more accurate screen than what is currently available through EFDS and MSS. And it can be performed either as a first-year test, so as a first line of screening, and it can be done as early as 9 or 10 weeks gestation, or it can be done subsequent to EFDS or MSS. So a patient may start with EFDS or MSS and then may decide to have an NIPT based on those results. Ohip funding is based on eligibility criteria, and the patient can choose to pay out of pocket if they do not meet eligibility criteria at the time of blood work. So what does NIPT screen for? You might remember EFDS and MSS screen for trisomy 21 and trisomy 18 only. NIPT does screen for more conditions. So trisomy 13, it's also a life-limiting condition. In some ways similar to trisomy 18, also associated with multiple congenital anomalies and a high risk of miscarriage and stillbirth. Life labs can pick up some cases of triploidy because of their technology, and you may also have screening for sex chromosome differences. I'll talk about that on the next slide. There are some additional private pay options that sometimes people ask about, so specifically microdeletion syndromes. Microdeletion refers to basically a small piece of chromosome that may be extra or missing. And this can occur in any of the 46 chromosomes. There's really hundreds of microdeletions that can occur. and NIPT companies may choose to screen for one or a few of these microdeletion syndromes. Essentially, there's limited data related to the clinical utility of screening for these conditions in the general obstetric population. And the screening accuracy is not well established. Certainly, the current evidence points to the fact that the screening accuracy is not nearly as robust as it is for the screening for Down syndrome, trisomy 18, and trisomy 13. So the SOGC guidelines do not support screening for microdeletion syndrome, and that's very much in line with many international guidelines. So what are sex chromosome differences? I'm just going to have a couple of slides on this because I think it's important. It refers to a variation from the typical number of sex chromosomes. So typically you have, 46 XX for a girl, and a boy, 46 XY. But you can have variations of that. You can have 45X, which is Turner syndrome, 47 XXY, which is Klinefelter, and so on. They're fairly frequent conditions, actually. It's just that a lot of people who have them might not even know that they have them. And I would say that the NIPT positive results for sex chromosome differences, when I worked as a genetic counselor, where there were some of the more difficult cases from a counseling perspective, and I think the emotional implications for the pregnant individuals. And that's part of the reason for that is because these conditions have such a variable presentation. Overall, they're milder compared to Down syndrome and certainly trisomy 18 and trisomy 13, but they're certainly not completely benign. They're still associated with some medical and learning challenges. The features include, taller short stature, infertility, delayed puberty, hypotonia, learning challenges, but not usually intellectual disability, anxiety, and other psychiatric challenges. I do like this leaflet, so I'm linking to it. It's just a 2-page leaflet. If you don't have a lot of time to talk about these conditions in your office, I think the least you can do is just, maybe hand out a pamphlet just to let people know this is what these conditions are. You're not just testing for the sex of the baby. I think an important consideration is that the NIPT performance is lower for sex chromosome differences than for trisomy 21, 18, and 13. We don't have born data available yet. It's actually difficult to analyze because of the milder presentation of these conditions. And I think an important point when you're thinking about Dynacare versus Life Labs is that you can actually opt out of screening for these sex chromosome differences through Dynacare, but you cannot opt out through Panorama. So I think it can be a bit challenging because Life Labs can be more widely available than Dynacare. But that's something for you and I think your patients to consider. Essentially, the more things you add to a panel, the higher the chances that the patient is just going to get something back that may or may not be a true positive, and it's just something that they have to deal with and that you have to refer on. In terms of the performance of NIPT, so it's we keep saying it's a really good screen. It's superior to enhanced first trimester screening. So what does that really mean? This is the born data for it, and essentially it's mostly 2 NIPT labs that contributed to this provincial data. It's mostly Dynacare and Life Labs, but Illumina also contributed to it. So the detection rate for Down syndrome is very high. It's 99.5%, trisomy 18, 96%, trisomy 13, 91%. So essentially, this is the probability that a pregnancy with Down syndrome will get a high risk result using NIPT. False positive rate is quite low. It's under 0.1% across the board. Okay, one more question for you. Can NIPT done for twin pregnancies? Yes or no? Okay, yeah, so 4 people said yes, and that is the correct answer. We can definitely do NIPT for twin pregnancies. We don't have born data on this yet either, just because twin pregnancies are not as common as singleton pregnancies. But a recent recent meta-analysis was published by Fetal Medicine, the Foundation, and they found that the detection rate for Down syndrome in twins was 99%. Overall, the performance was lower than for singletons, but better than any other screening method for twins. There's not enough data for trisomy 18 and trisomy 13 to really speak to the performance for those, but for Down syndrome, it's quite good. The downside is that there is a higher chance of the NIPT failing when you have a twin pregnancy. And I will talk about that in one future slide. Okay, I have one more question for you. So let's say we have a patient that presents to you at 10 weeks gestation. What would qualify them for Ohip funded NIPT? So if 41 years old, or has a child with Down syndrome, or is 36 years old and expecting twins, or has a child with autism, and you can select all the situations that would get them Ohip funded NIPT. Okay, yeah, I'm glad nobody picked the child with autism. That would not qualify them for Ohip funded NIPT. But all the other 3 scenarios actually would qualify them for Ohip funded NIPT. And I'm not surprised that not a lot of you answered this, because this is actually one of the temporary criteria that is in place that was instituted due to COVID. So I did want to bring attention to that, and you'll see it on the next slide. So these are the full criteria for Ohip funded NIPT. You have category 1 criteria. So this is when an NIPT can be ordered by any physician or nurse practitioner. And category 2 criteria is when it has to be ordered through a genetics or MFM specialist. Those are mostly related to ultrasound anomalies, soft signs. So I would say contact your local genetics center to see what their referral guidelines are, because there is some variability there. So you can order NIPT if there's a positive EFTS or positive MSS screen, if the patient is carrying only 1 baby and will be 40 years or older at the time of delivery. You can also order if the NT is 3.5 millimeters or higher, but that will change in the future. I expect that it will be moved eventually to a category 2 criteria. I would say if you see this NT measurement, don't bother ordering NIPT, just send to a genetic center or offer a referral to a genetic center. Previous history of Down syndrome, trisomy 18, trisomy 13, and now during the pandemic, essentially, if you have a twin pregnancy and that pregnancy cannot access an NT, they can get Ohip funded NIPT, and that's because MSS is not an option for them. We also made it easier for twins in general to get Ohip funded NIPT. So if the maternal age is 35 years or older and they're expecting twins, they can get Ohip funded NIPT. So that's something that a primary care provider can order. You don't have to refer to a genetic center for that. And these guidelines are in place until March 2022, but we're hopeful that it's something that will stay on. So this is what the OHIP-funded NIPT requisition looks like. It's 2 pages. I'm just showing you the Life Labs one, but Dynacare is very similar. So you would select the panorama prenatal test. I would ignore these microdeletions. You can choose to find out the sex of the baby. And then the MOH criteria on the second page. If you're a primary care provider, it's really the category 1 criteria that you would be focused on. What I mentioned about twins is actually not, it's not listed on the requisition because it's just meant to be temporary criteria. So they never made it into this version. So if you have a twin pregnancy, let's say she's 36 years old or will be 36 at time of EDD, you physically have to write that out on the second page of the requisition. And NIPT labs are well aware of these temporary guidelines, and they will go through. It's not going to be any issues. So in terms of the time, how to order NIPT for your patient. So OHIP-funded NIPT can only be done through Life Labs and Dynacare. When we're talking about private pay NIPT, the same 2 labs, so Life Labs and Dynacare do offer private pay NIPT, but you have to use a different requisition. And we don't have that on our website, but you can go to their websites and pull it up. And just make sure that you are using the correct requisition. If the patient shows up at the blood lab with the private pay requisition when they should be having the OHIP-funded requisition, they're just going to get turned away. The price for Dynacare is $495. Life Labs is $550. There are, a growing number of other commercial labs that are providing NIPT, but the testing is actually done outside of Canada, and this, variable costs. What I'll say is that at Born, we're mostly capturing data from Dynacare and Life Labs, and we're only now starting to capture data from other companies, but it's just a little bit more tricky because the testing is done outside of the country. So it's a buyer beware situation. We cannot vouch for the performance of these other screening tests. The SOGC recommends doing the blood draw at 10 weeks, even though with Life Labs, you can do it as early as 9 weeks. The results, according to the labs, it takes 7 to 10 business days. And the results are reported as high risk or low risk, but sometimes the NIPT can also fail. So what happens if you get a high risk result? I think it's a good time to mention to be wary of the data that is presented on NIPT lab websites. I still see a number of them mentioning a 99% accuracy rate for NIPT, and this is misleading at best. Most people would assume that this means that their result will tell them pretty much for sure whether the baby has one of the conditions or not, and this is not true. The metric that tells you what the chances that the baby has the condition when you get a high risk result is called the positive predictive value. So it's not the detection rate, it's the positive predictive value. Okay, so this is what you see here in the third column. So when you get a high risk result, the patient will ask, how likely is it that the baby has the condition? And the positive predictive value, that's what will answer that question. These are average numbers. The actual specific number for that individual may be different because you also have to take into account the clinical scenario. But on average, if somebody gets a high risk result for trisomy 21, there's a 95.5% chance that that's a true result. So that's not 99%, that's 95.5. For trisomy 18, we're looking at 92.3%. Yeah, and then if you have a low risk result, the patient will want to know how likely is that this is a true result, that the baby actually doesn't have the condition. So what they're asking for the negative predictive value. So in this scenario, the accuracy is quite high. You can be pretty sure that, in fact, the baby does not have the chromosome condition, not 100%, but over 99.99% in most scenarios. So just the way the test is set up, we can be more sure of the result when we get a low risk result than when we get a high risk result. And this sort of summarizes what I said. So when you get a high risk result, there's a significant chance the baby has the condition, but it's still a screen, it's not diagnostic. The next step really is to offer referral for genetic counseling. Options include invasive testing and ultrasounds. Yeah, it's an important factor to keep in mind that, you know, it doesn't necessarily have to lead to an invasive test. I think it's just a really good opportunity for the individual to, you know, talk about the results and see what the options are. And even if the patient decides not to go ahead with invasive testing, as it often happens, you know, they can still have non-invasive investigations. It can result in, you know, more close ultrasound monitoring. It can result in, you know, changing the delivery plans. So it can have significant implications for the management of that pregnancy, even if the patient does not go ahead with a diagnostic test. And I think that's an important consideration for your counseling. If you get a low risk result, really the patient can go ahead and have, you know, routine care if there's no other pregnancy concerns. So what happens when we don't get a result? Nobody likes this. It can happen for very different reasons. It can fail for the whole thing. So just the whole test is just inconclusive, or it can just fail for the sex chromosomes. There are many biological causes for why an NIPT may fail, which is unrelated to the fetal chromosomes. So if you're doing the NIPT too early, that can result in a failed NIPT. There's a higher chance of the NIPT failing. Also a higher BMI, IVF pregnancy, twin pregnancy, those are all risk factors for NIPT failing. It helps to call the genetic counselor from the testing lab to give you a sense for what the cause for the failed NIPT may be, even though there should be some information on the report as well. The majority of failed NIPT pregnancies are healthy, but there is an increased chance for an underlying chromosome abnormality, and we're hoping to publish on that soon. The follow-up really depends on the situation. You may be able to repeat the blood draw. It will say on the report whether that's recommended or not. I would not recommend repeating it more than once. You can also consider doing an alternative screening test like EFDS or MSS, detailed anatomy, ultrasound, and you can consider referral for genetic counseling just because of this increased chance for a possible chromosome difference in the baby. All right, so you have a patient that chooses private pay NIPT at 10 weeks and has a low risk result. What further screening options do you offer? Anti-ultrasound, EFDS, maternal serum screening, or detailed anatomy ultrasound. And you can choose more than one option. Okay, well, that's very good. Yes. So, yes, so you would choose NT and, or you would offer an NT ultrasound and you'd offer a detailed anatomy ultrasound. You do not need to follow up an IPT with enhanced first trimester screening or maternal serum screening because, you know, why would you do a more inferior screening test after an IPT? It really doesn't make sense. And also we don't recommend doing EFDS or MSS just to look for placental markers. The markers on their own from EFDS do not have good predictive power for placental dysfunction, but do offer the anti-ultrasound, which I think it looks like a lot of you are already aware of that. An increased NT has been associated with many chromosome differences, single gene disorder, structural abnormalities. This is the overall pathway that puts it all together. So if the patient declines screening, you can offer ultrasounds. If they accept screening, they can have first year NIPT as discussed. And then you'd offer anti-ultrasound, or the patient might have EFTS or MSS. They can get a screen positive result, or they can get a screen negative result. What happens if they get a screen positive result? Is that something that should be dealt with in primary care, or is it something for a genetics clinic to deal with? The issue is that if all screen positive patients were referred to genetics, it would result in very high volume of referrals and delay of care for the patient. So a lot of genetic clinics are now not accepting referrals just for screen positives. So it's good to have, I guess the ideal is to have a discussion as a primary care provider, to have that initial discussion with the patient where you give them the option of no screening versus Ohip funded NIPT at that point, or option of prenatal diagnosis. And of course, if the patient wants an Amnio or wants to talk, or really wants to speak to a genetic counselor, of course, you can refer on at that point, or if the NT is 3.5 millimeters or higher. So CVS, I'll just have I'll spend just a couple more minutes talking about CVS versus Amnio, and then I can take your questions. So when you're comparing NIPT and invasive testing, including CVS and Amnio, the timelines, of course, are going to be different. So CVS is done between 11 to 14 weeks gestation. Amniocentesis is done from 15 weeks onward. NIPT is the earliest prenatal test that you can have. It can be done, as you know, at 9 or 10 weeks gestation. So that is an advantage of NIPT. Prenatal diagnosis and NIPT are also different in terms of scope. So NIPT, I already told you what it screens for: trisomies 21, 18, 13, and 6 chromosome differences. With prenatal diagnosis, you can get a rapid test result in 2 to 4 business days, which looks for those exact same chromosome differences as NIPT, but it's considered diagnostic. And depending on the center and depending on the indication, the patient may also get a microarray. So I don't think anybody does karyotypes anymore, but it's just the microarray basically looks at all the chromosomes at high resolution, and it can pick up those microdeletions and microduplications that I talked about earlier. So these are, all the different microduplications and microdeletions that can happen, and they're all associated with different things. They vary in severity. Some can be more severe than Down syndrome. So certainly for an increased nuchal translucency, microarray would be included. Single gene testing may also be done. So for an increased NT, a lot of centers will do testing for Noonan syndrome because it's an association with an increased NT. So these are like just a summary slide of the differences. NIPT is non-invasive, can be done earlier, but it is a screen, does not screen for everything. It can fail, and it cannot be done for vanishing twins. So this is a pregnancy that started out as a multiple pregnancy with subsequent loss of fetal heartbeat or loss of the embryo in one of the pregnancy sacs. So if you notice that on a dating scan or NT scan, you should know that you cannot do NIPT for that pregnancy. You actually can't do EFTS either. So and the option is to do MSS or combine NT with MSS. In terms of the invasive diagnostic testing, while it is diagnostic, it can be more comprehensive. There's a risk of pregnancy loss, but there's lots of studies that show that the risk is lower than what the traditional figures indicate. So you can have a look at this meta-analysis on your own time, but the risk from CVS is quoted to be about 0.22%, and the risk of amnio is 0.11%. So 1 in 900. So lower than what is traditionally quoted for sure. With CVS, there's a small chance of getting an ambiguous result, which might require follow-up testing. And, it has to be organized through genetics or MFM. And, even with invasive testing, you can get an inconclusive result, or you can get a result from microarray that you're not really sure how to interpret. This is happening less and less, but it can still occur. These are just some resources. So you can obviously go to our website. We have a prenatal screening leaflet that we created in collaboration with the Education Working Group. And there's also Genetics Education Canada, which has a lot of information on things other than prenatal screening. And we have OMAMA, which is really part of Born, that has a lot of Ontario-based resources. And this is how you get in touch with us. And please follow us on Twitter if you have Twitter, or we can add you on our mailing list. I promise we don't send spam, just important information, occasional. And if you can fill out the short feedback survey, also would be much appreciated. We're working on an NIPT leaflet for providers. So one of the questions is just, what topics do you think should be included in that leaflet? Your input would be greatly appreciated. We have a phone line Monday through Friday, 9 to 3. You can send your patients to us, or you can call yourself. Yeah, and I think that's about it. Sorry.
No, you did great, Joanna. And I just wanted to thank you so much for all the information shared. I think there's a lot to be shared, and sometimes it's difficult to remember all the details. So as my colleague had put into the chat box, we will share PDF slides of this presentation, and the recording of this webinar will also be posted within our CMNRP website. So if you want to get back to anything, you will have the availability to do so. And Christina had put all of your resources that you had shared in the previous slides in the chat box as well. So if people are wanting to have it right away and not wait for the slides, they can start having those resources at their own tip. But I'll bring it back to Christina, and we can go to the Q&A box, because we had a few of them that we would like for you to answer, Joanna.
Perfect. Yeah, thank you so much. So the first question is about the timing of gestational age based on ultrasound or the last menstrual period.
Oh, sorry. Yes, sorry. You're saying if we should go by ultrasound versus last menstrual period?
Yes.
Was that your? Okay, sorry.
Yeah, for the gestational age.
Yeah. So I think ultrasound is always preferred for sure. And in terms of the EFTS cutoff, it's actually based on crown rump length. So it has to be between 48 millimeters to 84 millimeters. So especially if someone is not sure of their, first day of their last menstrual period, or they have irregular periods, definitely recommend a dating scan just to make sure you're doing that NT at the right time.
Perfect. Thank you so much. The next question is about NIPT. And is there any talk of NIPT becoming the gold standard for genetic testing, which is Ohip funded? So like the enhanced first trimester screen now. That's one question. The second part of that is, will midwives be able to order NIPT in the future?
Yeah, it's, both of those are difficult questions. So yeah, I mean, there's no question NIPT is a more superior test. Right now, it's not fiscally realistic for the province to fund NIPT for all pregnancies. We have a genetics working group, and we are looking at, the cutoff for EFTS. So, at what point we call something screen positive, to try to optimize the system a little bit better, and, make sure we give everybody, as many people as possible, an opportunity to have an IPT when it's indicated. Oh,
we're all getting that message.
I was going to say that's okay. Yeah, Amber alerts, we're all getting it.
Right,
So.
it's 12:55. Okay. And then with the midwives, yeah, I did present at the AOM, and I am well familiar with the frustration around that. At PSO, we're very supportive of the midwives being able to order NIPT in the future. And we do have a report going out to the ministry soon, if it hasn't gone already, where we have a very clear statement around our support. In the end, it's, I guess, the ministry's decision. And I'm not really sure, what goes into that. But yeah, it can be very frustrating, absolutely. And it's not in the best interest of the midwives, and it's not in the best interest of their clients.
Well, thank you so much for letting us know. That continues to be a discussion at the work group level. There's a question regarding NIPT. So do you recommend Harmony or Panorama?
Well, yeah. So
hard.
All good questions, but difficult ones.
No, those are all really good questions. So in terms of, I do have a slide on that, on the differences between Life Labs and Dynacare, and it's gonna make it into this slide deck, but it's on our website. They're both very similar in terms of performance, even though there's different technologies. For self-pay patients, Dynacare makes sense because it's a little bit cheaper. Life Labs is more widely available. I prefer Dynacare in some ways because you can opt out of the sex chromosome differences, and that was just a big part of my counseling when I worked in clinic, and I wanted to be able to give patients an option to opt out. Life Labs offers a little bit of an advantage when there's a twin pregnancy because it can check the zygosity, and that can have implications for management of that pregnancy. But yeah, I don't really think you can go wrong with either one. I think they both have slight advantages and disadvantages. Also, because of the technology that Life Labs uses, you can't do NIPT in a couple of circumstances. Like if you have an IVF with a donor egg, and if it's a twin pregnancy, you can't use Life Labs for it. Or if it's a surrogate with a twin pregnancy, you can't do Life Labs. So in those circumstances, you'd want to use Dynacare. Turnaround time is very similar. We have, born data for it. They're both keeping within their the turnaround time that they claim on their website, so 7 to 10 business days.
So following up on patient counseling, there's a question here about handouts and resources being available in French.
Yeah, yes, yes, it's absolutely. There's a great need for that. We are actually in the process of getting some material translated in French, specifically the prenatal screening leaflet. It will happen, and we're also hoping that we'll be able to get it translated in other languages as well. But I am not sure if and when that will happen. But certainly, yes, there will be a French version of the leaflet. We're also working with the Education Working Group on a leaflet for NIPT, and that will be published by the end of the year. And both Catherine and Christina have been involved with that group, so thank you for that. And yeah, that I would expect that will be translated into French as well.
Perfect, thank you so much. So we have a couple more questions yet, if people can hang with us. If not, if you have to sign off, no problem. We will follow up with those handouts and other resources. So the question here is, what is the added value of the NT with the NIPT if they're going to have a complete morph scan in a few weeks? Would the complete morph scan be more informative than an increased NT?
No, it's a very good question. So with an increased NT, first of all, it can be normal variation. Second of all, it can be one of the common aneuploidies, trisomy 21, 13, 18. But it can also, there's also an increased association with those microdeletions and microduplication syndromes. So smaller pieces of chromosome that could be extra or missing. And those occur in about 5% of pregnancies that have an increased nuchal translucency. Some of those microdeletions and microduplications can also go along with ultrasound findings, but that's not necessarily the case. So you can have, a baby with a microdeletion on chromosome 1 that's, fairly common, which is associated with a completely normal ultrasound in a lot of cases, but that child will have developmental delays, which can be severe. So, I think the increased nuchal translucency can be sort of a red flag, and it can result in investigations other than a detailed anatomy ultrasound, which can provide more information. Also, some centers will do early anatomy ultrasounds if you see an increased nuchal translucency. So at Mount Sinai, when I worked, for instance, and we saw a referral for an increased NT, we would do a joint consult. We would send them for an early anatomy in the MFM clinic, and then followed by a genetic counseling appointment. So yes, they would be getting that morphology scan, but they will be getting it much earlier, so they will get information much earlier, and which can impact the management of the pregnancy. Also, an increased nuchal translucency is associated with Noonan syndrome, and again, Noonan syndrome, you could potentially have a baby with Noonan syndrome that has, a normal ultrasound, especially depending where that ultrasound is done, it might not be picked up. So, yeah, so I hope that answers the question.
Very complex, and what I'm impressed about is the genetic counseling phone line. I think it's an amazing resource. So just to remind people, that phone number is there on the site that families can call for information, and care providers can call. So I was actually impressed before when Ioana had actually shared about what kind of calls they were giving, what kind of advice. Like, it's very comprehensive. So it's a great resource.
Yeah, thank you, Christina, for pointing that out. And we're aware that it's a lot of complex information to relay, to someone that you're seeing in the first trimester, and there's just so many things to talk about in that initial appointment. So feel free to send the patients to us, and we can have that discussion to complement some of the information that perhaps you're not able to provide just because of time limitations.
So here's a question. I'll just read it out. So again, it's about the counseling and increasing confidence to have these counseling conversations. The individual says, I struggle to explain what a positive EFTS result and what exactly does it mean. Should I discuss the exact number they ask? I just want to say positive or negative, but what is the chance the baby is normal with a positive result? And I think you'd shared a few of those stats before, but maybe if you could just summarize that again.
No, for sure. And I didn't focus on that in the talk. So for sure. So when you get a result, you would focus on that number. So let's say it's it's a 1 in 300 result. The way you can explain it is you can also just put it into percentages. So really, it's a 0.3% chance that the baby has Down syndrome. And what we often do is we would flip it, 99.7% chance that the baby doesn't have Down syndrome. And you'll see a huge sigh of relief at that point. Because when you see a screen positive as a pregnant individual, your mind automatically thinks, oh my God, I must be really high risk. And then when they hear the number and they hear the percentages and they see it reframed, it really helps, I think. It helps calm them down. And then normally I would say, yes, most likely the baby doesn't have Down syndrome, but we do have this arbitrary cutoff of 1 in 350. And your risk can back higher than that. So you have an option to opt out of screening if you're feeling okay about this number. The second option is to have NIPT, which is non-invasive, and it's a more precise form of screening. And the third option is invasive testing. So I hope that helps. But I would say even if the result is screen negative, so let's say the number is 1 in 1,000, I would still relay that to the patient when you talk to them. So I wouldn't just say screen negative. I would say, your chance is 1 in 1,000, just because, the way people interpret numbers is so subjective. So I think it's important to give them the precise number.
Thank you so much. What I love about working with the education work group was about the family-centeredness of this. Just sharing information and respecting that families need the information. They need to explain to them in a simple way that they can then make decisions based on their values and beliefs going forward. So the resources that have been created so far and what you continue to work on is really that lens of taking very complex like science and translating it into something meaningful within that context of that pregnancy. So, so thank you so much for that thorough explanation there. I hope it helps. There's one final question. It has to do with some of the other options for labs testing. So can you comment or give some insight into some of the less expensive prenatal testing that are being promoted? So how do providers kind of manage that plethora of options?
So like I said, there are other labs that perform NIPT outside of Canada. I think it's starting to become more popular now. I had experience with it when I worked as a genetic counselor at Mount Sinai. In my role at PSO, I cannot really comment about it one way or another because, like I said, we don't really collect a lot of the data from them and we can't really vouch for its performance. But it is a CLIA certified lab. They offer a lot of other genetic tests. It's used quite extensively by many genetic clinics for other purposes. If they offer the screen for $99 US, and cost is a big consideration for patients. So I think you just have to, have a balanced discussion with your patient. At the end of the day, you have, you make the best decision for that patient. It used to be a little bit of more convoluted process before. Okay, you couldn't really go to a blood lab to get the blood draw. So the patient would get a kit, and then there would be a third-party phlebotomist that would come to their house and get their blood. And of course, during the pandemic, that was a bit complicated. I don't think they were even doing it for a while. So I know that they've partnered now with clinics. So they do have a number of blood collection labs in Ontario, which makes it easier to facilitate the blood work. And I'm happy to put anybody in touch with the appropriate person at Invita if you want to find out more information.
Thank you so much. That looks like all the questions that we have in the chat. Over to you, Catherine.
Yes, sorry. So we're a little bit past our time, but I think the Q&A piece is so important to have those questions and answers. So thank you, Joanna, again, for staying and sticking with us a little bit longer, and for our participants as well. And as I said, we'll make sure that all the resources, the PDFs and the recordings are available on our CMNRP website. So in the next few weeks, that should be available. And we'll reach out to all the registered emails as well to let them know that this is available to them. And if they have any more questions, they can reach out to you specifically, Joanna, at the PSO Born email as well.
Thank you all for your questions.
Thanks, everyone. Have a great afternoon.